into, now that we can read the x-rays, interpret it properly for our expected clinical outcome, I'm going to go over 3 techniques and show you some actual cases where we did the surgery using this type of technology. So the first technique is a scan only. That's where you take the scan, you email us over the DICOM, and then we fabricate a surgical guide. You can't do that on all patients, but there are some that you can do that on. The next way is a stone model, and that's where you take the scan of the patient, send us over the DICOM, and then mail us over a stone model. And so that one, again, not all patients are candidates for that. It really depends on their anatomy. I'll discuss that in more detail here in a minute. And then the last one is the most commonly used one. This is a radiographic guide technique. And this one can be used on every single patient. You just have to build a radiographic guide prior to scanning the patient on the arch that you're placing the implant on. So the first technique, which is the scan only, this particular case, no guide, no model was sent to us. It was just the scan. And here's the pre-op radiographs. And the plan was extract all the dentition. We made a bone reduction guide and then a bone supported guide on top of that. And then there was immediate temporization as well. This type of technique is probably, out of the 3, the least accurate. And I would say the stone model is probably the most accurate. I'll just kind of show you why and show you the discrepancies in accuracy with the different types of techniques. So this is one where this is our bone reduction guide and then our surgical guide that we fabricated just off of the CT scan in the software program. And then here's the clinical image. We're extracting the dentition, and then we move on to use the bone reduction guide once all of the dentition is extracted. And then the surgical guide fits on that bone reduction guide because we reduced the bone in the software, and then we fabricated the surgical guide on that reduced bone in the software. So it's going to fit exactly, as long as the bone reduction guide is used properly, the surgical guide is going to fit properly as well. And this fit beautifully when we put it on there. And then this is the final outcome of that. You'll notice, I mean, these would be tough angles to get if you were freehanding versus using a surgical guide for a case like this. So it worked out really great. And what we did on this case is we did immediate temporization. And so we used a model, and we did the entire surgery on the model. And then we prepared that, the temporaries off of that. And so these 2 pictures depict the inaccuracies that can come from this type of method, which is very minimal for what we're doing. You know, going from just the DICOM data, reducing the bone down, placing a surgical guide on top of that, and then immediate temporization. The only discrepancies is this little gap here that you see, because the model is what we did in the lab, and then the temporaries, this is during the surgery, we set the temporaries and used some flowable and made it adjust to how the implants were actually placed clinically versus how we placed them in the lab. And so you'll notice here that you have a little bit of a gap here and a little bit of a gap here, which, again, very small discrepancy for what we were doing and how we were using this type of technology. So I wouldn't suggest immediate load for, finals. So you definitely want to do immediate load for temporization or immediate temporization with the anticipation that there's going to be chairside adjustments at the time of surgery. Okay, case number 2. This is stone model surgery. And this one, as I said, I feel like this one's one of the more accurate out of the 3. But not all patients are a candidate. What makes a patient a candidate for this is the ability to see the occlusal surfaces. We have to be able to see the incisal edge. We have to be able to see every cusp and groove pretty clearly, because what we do is we take a model and we merge that with the scan. So here's the scan of the patient. Patient's not wearing any type of appliance. It's just the DICOM scan. And then here is a stone model. And what we do is we transfer that to a digital replication. We have a digital duplicate of that model. So there's a few ways that we can digitize that model. One way, and this eliminates you shipping us a model, you can scan the patient and then scan the model with your DICOM. Or a more accurate way is you scan the patient, send us the model, and we use a high-powered STL scanner to make that digital duplicate. And the reason I say that's a lot more accurate is because when you scan your model on your CT or CBCT machine, then that's subject to the Hounsfield unit threshold, as I was discussing earlier. And we can still get very accurate results. We've done that a lot. It's a quick and easy way to do it, especially if there's a lot of time constraints. It does take a few extra days for us to scan the model. But the STL, what that is it's surface only. And what you scan, there's no threshold that it's on. So what you scan is exactly what you get in your computer. And so that's what makes it pretty accurate. And so we take the original scan, we take the model, and then we merge those two together, and we create, and then we treatment plan off it and create a surgical guide off of your model. And so this is the final surgical guide for that case. And so that's a really good technique, but if the patient has a lot of dental restoration, there's a lot of noise and scanner at the occlusal surface, then we won't be able to do it that way. But if there's a lot of natural dentition, and there's enough natural dentition where we can get enough points to merge it accurately, then that's a really good option to go with. The last method is our radiographic guide surgery. And this is the most common used radiographic guide surgery, or the technique. And so what we did, this is a maxillary arch. There's 6 gutta-percha markers in there. We're doing 2 implants in the posterior. And so we scanned the patient wearing the radiographic guide, scanned the guide by itself, merged it together, did the treatment plan, placed 2 implants in the posterior, and then fabricated the surgical guide. The implants were placed using the surgical guide. And then, this one was done flapless. They did a tissue punch. I've seen it done a lot of different ways. I've seen them do a little window, or I've seen them drill straight through the soft tissue. So that's personal preference. That's the more common approach or technique.